want to emphasise that ensuring colleagues are working in a safe environment, in an environment that is free from discrimination, that in and of itself is morally appropriate.
Hello, you're listening to the Medical Protection Podcast, Good Medical Practice series. I'm Dr. Sabira Hughes, one of the medico-legal consultants at Medical Protection. By way of introduction, I have been at Medical Protection for 5 years. Prior to that, I worked as a lawyer specialising in healthcare law for 12 years, and prior to that, I worked as a doctor. My current role is to support and advise doctors who are subject to a variety of medico-legal processes and issues that affect their clinical practice. For today's podcast, I'll be joined by our previous co-host Ceylan Simsek and our previous guests Yael and Tista from the GMC. In the last 2 podcasts, we talked about the changes that are happening to good medical practice, how the changes will impact doctors in the UK, and which stakeholders the GMC has liaised with. This podcast will focus on tackling discrimination and the changes in the guidance in that regard. I would like to start by asking what might be a very obvious question, but what does the GMC mean when it refers to discrimination within the guidance? Yael, perhaps you could help us with that.
Yes, of course. It's a good question. It's important to be clear about what the standards say. Discrimination used to be a neutral word. It just meant deciding between things or prioritizing. And we expect doctors to prioritize care on the basis of clinical need. That's the long-standing duty. But the word discrimination has lost that neutrality in everyday language. It means something quite specific now. Essentially, it's about treating someone differently in a way that's unfair. Treating them differently because of a particular characteristic, their age, sex, sexual orientation, race, etc. And there's a list of characteristics that are protected by legislation, the Equality Act 2010. So you must treat patients fairly and not discriminate against them. You must treat colleagues fairly. And if it's part of your role to help staff access training and development opportunities, you should do that fairly. I did a bit of digging, and the duties relating to discrimination in relation to both patients and colleagues have both been in good medical practice since the very first edition in 1995. And a duty to call out discriminatory behaviour if you witness it, to challenge colleagues who don't follow this guidance, was introduced in 2006. And we've spoken a bit about the bystander duty in Good Medical Practice 2024. For this update, where we talk about how you mustn't discriminate against colleagues, we've widened the description, so we also say you mustn't bully colleagues or harass them or abuse them. And the standards go further than the law by telling doctors that they mustn't abuse, discriminate against, harass anyone for any reason. So not only based on protected characteristics, but any kind of abuse, discrimination or harassment is unacceptable.
Thank you, Yael. And when we're talking about discrimination, what comes to my mind is unconscious and or conscious biases. And I just want to find out, Tista, whether these were considered when redrafting the good medical practice.
Thanks, Ceylan. I think that's a really important question. And we accounted for bias in the duties themselves, but we also accounted for bias in our approach to drafting GMP. So it's probably helpful if I say a little bit about both those strands, if you will. I guess in society now, there is much greater recognition of bias and the harmful impacts. And back in 2018, we commissioned a report called Fair to Refer, and that was to look at why minoritised ethnic doctors are disproportionately referred to us. And that's something I'd really encourage listeners to have a look at, actually. Now, that report includes over 40 references to bias from things like insider and outsider group dynamics, the lack of feedback that those outsider groups are often subject to, the lack of induction that our IMG colleagues, international medical graduates, often face, and as Yael touched on, the lack of fair access to training opportunities, etc. All of those things are forms of bias, and they can be overt, they can be covert. So tackling bias has been a cornerstone of our equality, diversity and inclusion work at the GMC. And the new standards give us that additional opportunity to tackle these issues. And our research and consultation really affirmed the importance of that focus. It's what doctors and patients really wanted us to strengthen. And as a result of that, in paragraph 54, we explicitly talk about the risk of bias. But in several other paragraphs, we also talk about fairness. So paragraph 64, it is the one where we talk about fair access to training, develop employment opportunities. And that is therefore essentially about eliminating bias. So that's the standards themselves. In terms of our approach to the consultation and eliminating bias in the drafting process, we work really hard to ensure a diverse response so that the duties are fair through diverse lenses. And I know I've talked about this work in previous episodes, so I won't labour it too much, but the expertise of representative organisations, for example, diaspora organisations, other marginalised doctor and patient groups, that helped offer real scrutiny on how the updated standards might work for them, and their input really helped craft what we now have. And for listeners who are interested, there are resources on our website that tell that story, and we can include the links in that in the podcast information.
That's really interesting. And Yael, did you have any comments to add?
Yes, if I could just, you mentioned the terminology unconscious bias, and the draft of Good Medical Practice that we consulted on back in 2022 included the wording unconscious bias, and it wasn't well received. Some respondents felt it was kind of jargon. Some felt that the concept of unconscious bias had fallen out of favour, or that we were in danger of creating a standard that would be impossible to meet. You know, if we were saying to be aware of unconscious biases, then by their very nature, you're not aware of them. So we drew back from the term in the final draft and instead used wording that I think gets to the nub of the issue, which is about encouraging reflection, asking doctors to be aware of the risk of bias, as Tista mentioned, and also to consider the influence that their life experience, including their culture and beliefs, to consider the potential impact that this might have on their decisions and actions. And there's also a new duty that mirrors this one. So as well as being aware of how their own life experience may bias their views of others, the updated Good Medical Practice asks doctors to show respect for and sensitivity towards others' life experience, cultures, and beliefs. And both these things are crucial in encouraging environments that are fair, free from discrimination, and where people are respected and valued as individuals, which is one of the key themes that we've been talking about over the last couple of weeks.
Thank you, Yael. And I think that ties into my next observation, if I may. It was interesting to me to see that in the opening introduction to Domain 3 in Good Medical Practice, it is explicit when it states that everyone has the right to work and train in an environment which is fair and free from discrimination. Now, some doctors might be wondering what tackling discrimination has to do with delivering good patient care. And I wondered, Tista, if you could help with your thoughts on that.
Absolutely. Thanks, Sabira. Again, I think that's a really good question. And I guess in short, it has a lot to do with good patient care. But just before I get into that, I want to emphasise that ensuring colleagues are working in a safe environment, in an environment that is free from discrimination, that in and of itself is morally appropriate. And we very much want GMP to help inculcate that, because those vile stories that we hear of misogyny, homophobia, racism, some of the recent stories on ableism, it needs to stop. But in terms of patient care, there is a significant body of evidence which demonstrates that decent working environments, free from discrimination, where doctors feel valued, ultimately have a positive effect on patient experience and outcomes as well. Now, that does come through, for example, in my team's regular engagement with the profession. It came through in our consultation for GMP, but there's also research listeners might be interested in. We commissioned a report, Caring for Doctors, Caring for Patients, back in 2018. And that speaks to how doctors need a number of factors to be in place, one of which is a sense of belonging and how that impacts on patient care. You and listeners might also be aware of Civility Saves Lives. And the data show that in addition to well-being impacts, 78% of those subject to incivility at work reduce their commitment. 38% find a reduction in the quality of their work. So civility saves lives, literally. I can use that word with impunity. And actually, you know what? We don't need data to understand that if you're starting your day at work and you've been subject to racism in a corridor conversation, and then you have to scrub up to work with a consultant who makes sexualized comments towards you all the time, you're not going to be at your best. So, yes, in addition to that moral imperative, tackling discrimination in working environments absolutely does affect patient care.
And Yael, talking about a safe working environment, the updated standards introduce a new duty about unacceptable sexual behaviors towards colleagues and not just patients, as was the case previously. What prompted this change?
Well, I don't think any of us, really understood the extent of this type of behavior in the work environment until the Me Too movement prompted more and more people to speak out. And things have really changed. There's been a real shift in society towards calling out these behaviors. Maybe before people just thought it was something you had to put up with if you wanted to be successful. But now that we know how pervasive this kind of behavior is in medical training and working environments, and now there's evidence that shows just how much damage it can do, not just to people's careers, but their well-being and their ability to provide good care, we had to include something in good medical practice about it. And so in coming up with the wording, we worked closely with the campaign group Surviving in Scrubs and others to make sure that the wording of the standard addressed not only clear-cut cases of sexual harassment and sexual assault, but also, crucially, lower-level pernicious behaviours that can often be dismissed as banter or miscommunication, but that make people feel embarrassed or unsafe and prevent them from doing their best work. The wording's clear, and again, the description of unacceptable behaviour goes further than the legal definition of harassment. It includes verbal or written comments, displaying or sharing images, as well as unwelcome physical contact. And we've got more detailed guidance on maintaining personal and professional boundaries.
Thank you, Yael. So I wanted to ask whether the updated standards say anything new about the rights or duties of doctors who are subjected to discrimination by their patients. For example, when the relationship between a doctor and patient has deteriorated to such a degree that they cannot treat the patient effectively or safely, then how can the new guidance help?
Well, we know that doctors can sometimes experience abuse, harassment, or discrimination from patients. And like we've said many times before, we strongly believe doctors have the right to work in an environment free from discrimination, whoever the source of that discrimination or abusive behaviour is, whether it's a colleague or a patient. But when it comes to patient behaviour, context is always going to be important. What information do you have about the patient's mental state, and how serious is their condition? How urgently do they need medical treatment? Adopting a zero tolerance approach could mean that some patients with conditions that affect their behaviour might never get the treatment they need. So while we don't expect doctors to just put up with discrimination or harassment, Their right to practice in a discrimination-free environment needs to be balanced against the patient's right to access care to meet their needs. But having said that, good medical practice accepts that sometimes trust between a doctor and a patient can break down to such a degree that the doctor simply can't continue to provide good clinical care to that patient. And we have more detailed guidance on ending professional relationships with patients, which looks at this scenario and sets out the steps you need to take in those circumstances. And as well as the more detailed guidance, we've also got a page on our ethical hub about racism in the workplace. Perhaps we can link to it from the podcast description. And that page has advice about what to do if you witness racism in the workplace or if you experience it directly. It includes case studies based on doctors' experiences, as well as advice and best practice examples. It links to lots of other sources of information and help, as every page on our ethical hub does.
Thank you, Yael, and certainly we can link that into our podcast description. Tista, finally, we mentioned a lot of training and resources during this podcast, but I just also wanted to ask, what training and resources does the GMC provide to support doctors in promoting diversity and inclusion for our listeners who want to take this off the podcast and expand their knowledge in this area?
Yeah, absolutely. As you say, we've spoken before about how, in addition to setting the standard, it is incumbent upon us to help colleagues apply them on the ground. And work on anti discrimination is so critical and, frankly, so challenging. That's where my team in outreach are investing the bulk of our energy. So we do that in a couple of ways. One is our work through employers. So my team meet every responsible officer and we're working with them to see what support is needed or indeed what good practice they can share in this space as well. We also have that focus through our work with colleagues on the ground. Last time we talked about the workshops that we deliver, but I didn't go into detail on the content. And a major focus of those workshops is anti-discrimination. So, for example, we've created video scenarios exploring things like a doctor being subject to racism, ranging the gamut from microaggressions to overt racism from a patient as well as colleagues. Yael mentioned surviving in scrubs before. We also work with them to create a video depicting sexual harassment, and that is very deliberately deeply uncomfortable and quite claustrophobic as a watch. And what our training then does, it delves into how colleagues can practically tackle these issues. So if you're a leader, what protective factors do you need to put in place? If you are, for example, if we're meeting with a group of F1s, okay, well, what are your sources of support? So we really look at that to equip them with the language and imbue them with confidence to escalate things. And if people are interested in that, our details outreach, GMC outreach are on the website. Again, we can include the link so colleagues can access our services. I think given that we're talking about tackling discrimination, there are other work streams as well in terms of training. So we've got programs like Welcome to UK Practice for our international medical graduates, and that is there to help tackle that lack of induction that I mentioned earlier. And indeed, the guidance that we produced with you, with MPS and the BMA and NHS England, welcoming and valuing IMGs, we do work to deliver that on the ground. So again, you can find out more about that by looking up GMC Outreach. And that's made me realise that I've talked a great deal about what my team do, which is slightly solipsistic of me. But of course, as Yael said earlier, do also have myriad resources online on the Ethical Hub on racism and sexual misconduct and various other topics. So yeah, but it's such a key area. There is a lot out there in terms of the training and support that we provide.
Well, thank you both for this fascinating discussion. It really is reassuring for us to hear that the GMC has put so much work into dealing with this important issue that our medical protection members unfortunately can face. So I want to thank you on their behalf for the work that you've done. And with that, we reached the end of today's podcast, Tackling Discrimination. Thank you to Yael and Tista for joining us today.
To learn more about what we covered today and who you were listening to, please take a look in the podcast description. Listen to more in this series of short discussions where MPS talks with the GMC about the key changes to the good medical practice. Tune in next week to hear us talk more about the key changes to the GMP. I've been your host, Ceylan Simsek.
And I've been your host, Sabira Hughes. Thank you for joining us.